Hello, everyone, and welcome to this webinar entitled Understanding the Translational Gap in Post-Resuscitation Care. Temperature Control Parameters Matter. Comprehensive post-resuscitation care, including the use of temperature control, is an essential link in the chain of survival. Temperature control is a bundled intervention with several different parameters, and the lack of a standardized intervention has led to variable treatment efficacy and patient outcomes. This webinar will review the literature, address rationale for the translational gap, discuss the need for a standardized definition of high-quality temperature control, and propose future directions for addressing this unmet need. This webinar was made possible through sponsorship from Zoll. I'll be the moderator for this event. My name is Fei Lin, Senior Editor of Gen Biotechnology, the peer-reviewed journal publishing original research and perspectives across the biotech field. We're pleased to welcome our speaker for today's event, Dr. Rachel Beekman. Dr. Beekman began her medical training in her home state of New York at Stony Brook University School of Medicine, and has since relocated to New Haven, where she completed her neurology residency and neurocritical care fellowship at Yale New Haven Hospital. Dr. Beekman is the first Yale alumni to continue as faculty in the Department of Neurocritical Care. She has a passion for treating survivors of cardiac arrest and is building a multidisciplinary cardiac arrest program. If you're in the audience, make sure to enter your questions in the Q&A box and stay tuned for the Q&A session at the end of today's webinar. With that, we welcome Dr. Beekman to the stage.
Hi, everyone. I'm Rachel Beekman. I am an assistant professor of neurology and a neurocritical care doctor at Yale University. And I will be talking a bit about post-resuscitation care and temperature control. I have no disclosures. The outline for today is that we're going to start by talking about the historical perspective of temperature control. We're going to review some data from trials and the state of the current guidelines. We're going to review current knowledge gaps, discuss the concept of high quality temperature control, and then end with some future directions. Before we get into a talk about hypothermia, it is important to address what we're trying to accomplish in post-resuscitation care. Hypoxic ischemic brain injury is the #1 cause of morbidity and mortality following cardiac arrest. It is the result of both the primary anoxic event that occurs prior to return of spontaneous circulation and the secondary brain injury that occurs in the hours to days following return of spontaneous circulation. In preclinical models of hypoxic ischemic brain injury, hypothermia restores and maintains effective cerebral blood flow, reduces cerebral energy expenditure, improves cerebrovascular autoregulation, and decreases intracranial pressure. The goal of treatment with hypothermia is to reduce reperfusion injury following return of spontaneous circulation. The clinical application of hypothermia actually dates as far back as Hippocrates in 400 BC. However, Dr. Temple Fay is credited with bringing therapeutic hypothermia into modern medicine with his invention of the earliest known cooling blanket, which is pictured here. While his work was actually centered around the treatment of chronic pain, his invention opened the door for further research using hypothermia. 2 decades later, Dr. Benson and Yates published a retrospective review of 27 instances of perioperative cardiac arrest treated with hypothermia to 30 to 32 degrees Celsius. Of the 27 patients, there were 19 who were unresponsive following return of spontaneous circulation. 12 of these patients were treated with hypothermia, and 7 were not. 1 in 7, so 14% in the group that was not treated with hypothermia, and 6 in 12, or 50%, survived without neurologic deficits in the hypothermia group. This retrospective study led to excitement about the potential therapeutic effects of hypothermia. The first prospective study of therapeutic hypothermia for out-of-hospital cardiac arrest was published in 1997. This study included 22 out-of-hospital cardiac arrest patients treated with hypothermia to 33 degrees Celsius for a duration of 12 hours, and they were compared to retrospectively collected normothermic controls. As you can see in Table 4, good neurologic outcome occurred in 54% of the patients who were treated with hypothermia versus only 13.6% of the group that had normothermia. This study is what set the stage for the seminal Bernard and Haka trials in 2002. The Bernard and Haka studies were the first prospective randomized studies of moderate hypothermia. And these studies showed a significant improvement in survival with functional outcomes. These findings resulted in an ILCOR recommendation for the use of hypothermia at 32 to 34 degrees Celsius in adult patients with shockable rhythm out of hospital cardiac arrest. Between 2002 and 2013, there was a pretty slow adoption of hypothermia and large criticism of the trials given the high rates of fever in the control arm. To answer this gap, in 2013, the TTM1 trial evaluated 33 degrees Celsius versus 36 degrees Celsius and found that there was no difference in the primary or secondary outcomes. Subsequent to the publication of the TTM1 trial, the ILCOR guidelines recommended the use of hypothermia with a target temperature ranging between 32 and 36 degrees Celsius. And this overall led to a slow transition away from the use of moderate hypothermia. Now, jumping ahead to 2021, the TTM2 trial was published, which evaluated moderate hypothermia versus targeted normothermia. This trial found no difference in primary outcome and resulted in many institutions shifting away from active temperature control towards a strategy of fever avoidance. The current guidelines recommend, at minimum, active temperature control aimed at achieving normothermia, but recognize that there are knowledge gaps that remain about which subpopulations may benefit from moderate hypothermia. And they also mention the unknown impact of early cooling, which we're going to spend a lot of time discussing today. There are several important knowledge gaps that we must acknowledge. Most of the published literature pertains to a small group of patients with witnessed shockable rhythm arrest of cardiac etiology. These studies may not be generalizable, especially in the US population. We'll discuss more later, but the temperature control is not a one-size-fits-all intervention, and similar to other critical care interventions, likely needs to be modified for the patient you are treating. Furthermore, temperature control is a broad term that would argue is not a single intervention, but rather a bundle of interventions. And we unfortunately still don't know the optimal parameters and how these parameters interact to influence efficacy. As I said before, the majority of published studies on temperature control to date have been really focused on cardiac etiology, with predominantly shockable rhythm arrest. But if you look at the largest of these trials, the TTM2 trial, the cohort has very high rates of witnessed arrests, 91%, bystander CPR, 82%. But you can also see that there are major differences in post-cardiac arrest illness severity based on the percentage with circulatory shock and the post-return of spontaneous circulation lactate levels. Consistent with these arrest-related details, most of these trials share a survival rate close to 50%. But on the contrary, our institution, which is located in the northeast of the United States, has much lower rates of witnessed arrest and bystander CPR, a significantly lower population of shockable rhythm arrest, and an overall higher post-cardiac arrest severity with higher lactate levels post-arrest, and the majority of our patients requiring circulatory support. And as such, our overall survival rates and good neurologic outcome rates are significantly lower than what has been reported in prior trials. The currently enrolling ICECAP trial is the first temperature control trial in North America, and it's including a population that is going to be much more similar to the patients that we see in clinical practice. So why do these differences in cohort matter? Well, there's a host of literature that suggests that the severity of post-cardiac arrest syndrome influences the neuroprotective effect of temperature control. Okazaki in 2019 performed a post hoc analysis of an out-of-hospital cardiac arrest registry, including 435 patients treated with temperature control. While they found overall that there was no difference between mild and moderate hypothermia, amongst those who had a post-return of spontaneous circulation lactate of 12 or higher, the adjusted predicted probability of 30-day favorable neurologic outcomes was significantly higher in those treated with moderate hypothermia. In 2020, the Pittsburgh group, led by Cliff Calloway, performed a retrospective analysis of over 1,300 patients treated with temperature control. They excluded patients with severe hypoxic ischemic brain injury, which was defined as the presence of cerebral edema on computed tomography or highly malignant EEG. In this cohort, patients with a higher illness severity, which was defined as a Pittsburgh cardiac arrest category score of 3 or 4, had improved survival when treated with moderate hypothermia. And on the contrary, patients who had mild illness severity, defined by a Pittsburgh category score of 2, had higher survival when treated with mild hypothermia. In 2021, Nishikimi performed a retrospective analysis of over 1,000 patients treated with temperature control using the RCAS score as a predictor of post-cardiac arrest illness severity. This group found that amongst patients with moderate severity post-cardiac arrest syndrome, which was defined as an RCAS score of 6 to 14.5, that moderate hypothermia was associated with improved functional outcome with an odds ratio of 1.7. In 2020, Kim and colleagues performed a retrospective analysis of 628 out-of-hospital cardiac arrest patients treated with temperature control. In the overall cohort, there were no differences in outcome between mild and moderate hypothermia. However, close to a third of the patients in the cohort presented with spontaneous hypothermia, which was defined as a presenting temperature of 34.7 or below. And in this group who presented with spontaneous hypothermia, the use of moderate hypothermia was associated with a lower rate of mortality with an odds ratio of 0.49 compared to the treatment with mild hypothermia. And lastly, in 2022, Natuma and colleagues performed a post hoc analysis of a prospective cohort study, including 279 out-of-hospital cardiac arrest patients treated with temperature control. In this study, post-cardiac arrest illness severity was defined based on EEG background at 12 to 24 hours. Amongst the patients with moderate encephalopathy, which was defined by the presence of burst suppression, a low voltage recording, generalized periodic discharges, or a discontinuous background, the treatment with moderate hypothermia was associated with improved outcomes compared to the treatment with mild hypothermia, with an odds ratio of 2.38. These studies all suggest that there's an interaction between the post-cardiac arrest syndrome severity and the neuroprotective benefit of temperature control. The way I like to think about this is that in mild hypoxic ischemic brain injury, these patients are at a high likelihood of awakening. And the use of adjunctive treatments for moderate hypothermia, such as sedation or paralysis for the treatment of shivering thermogenesis, may actually result in delayed awakening. And that increases the likelihood of inappropriate withdrawal of life-sustaining therapy in a group that would otherwise awaken. In these patients, the risks of treatment to 33 degrees may outweigh the benefits. In the patients with severe hypoxic ischemic brain injury, the mortality rate is very high, regardless of temperature control. And this also puts them at risk for side effects such as arrhythmia that outweigh the potential benefits. But the group with moderate hypoxic ischemic brain injury has the most to gain from moderate hypothermia. The important question then becomes, how do we identify these patients? And returning to the generalizability of the published data, if the benefit is highest amongst those with moderate hypoxic ischemic brain injury, then we must interpret the results of the TTM2 trial with caution, as this trial likely included a lower severity illness group. I love this figure from Tacone and colleagues, and this really shows the many therapies that we call temperature control. Temperature control is a complex and bundled intervention of which we need to set and define multiple parameters, such as the time to initiation, the induction time, the method of cooling, whether we're using ice packs, cooling blankets, surface cooling, with or without a feedback system, or the use of intravascular cooling, the duration and depth of therapy, adjunctive treatments such as the use of neuromuscular blockade or sedation for shivering thermogenesis, and the rate of rewarming. Each of these parameters likely influences the therapeutic effect of temperature control. And the lack of a standardized and rapidly deployable intervention has resulted in variability in practice. Further, the use of pragmatic design clinical trials has resulted in our inability to evaluate the single intervention, and this confounds our understanding of the importance of specific treatment parameters. Amongst preclinical models of hypoxic ischemic brain injury, moderate hypothermia consistently results in a neuroprotective benefit. As you can see in this study performed by Che in 2011, the neuroprotective benefit of hypothermia decreases with delay to initiation and actually is no longer present when hypothermia is initiated 8 hours after cardiac arrest. This data is not surprising, as we know that neuroprotective interventions in the setting of ischemia must be started early to mitigate reperfusion injury. The presence of a therapeutic window may partly explain the translational gap that we see when we compare preclinical models to what we are evaluating at the bedside. In this figure, you can see overall mortality on the left y-axis and the time to achieve target temperature on the right y-axis. The target temperature in these studies was 33 degrees Celsius. Each of these studies included somewhat similar populations of patients with predominantly cardiac etiology out of hospital cardiac arrest. Despite similar inclusion criterion, you can see that overall mortality ranges from about 28% to 52%. And you can see that overall, the studies that had a shorter time to achieve target temperature, which are in the middle here, all had the lowest mortality rates. Seen in green are the studies that use predominantly intravascular cooling, and you can see that these studies had overall shorter induction times. So if there is a therapeutic window, then you may ask why a sub-study of the TTM2 trial found no benefit in those with more rapid induction. However, if you look a little bit closer into this study, you can see that the sites that had the fastest induction rate enrolled patients who were older and had lower presenting temperatures, both features that are associated with higher mortality. Rapid induction has been associated with worse outcome, and this is likely because it reflects patient-specific factors rather than treatment-specific variables. The time to achieve target temperature is inclusive of both the pre-induction time, which is how long it takes the provider to initiate hypothermia treatment, and the induction time, which is the time that it takes for a patient to reach target temperature once hypothermia has been initiated. The induction speed depends on patient-specific variables, such as the presenting temperature and if they can resist cooling, so that patient's inherent ability to generate heat. It's been identified that patients who shiver or generate heat during hypothermia have overall better outcomes, while patients who do not resist hypothermia and therefore have rapid induction have poorer outcomes. Thermogenesis, which is essential for homeostasis, is controlled by the hypothalamus, and it's hypothesized that patients who fail to resist cooling due to dysfunction of thermoregulation likely have severe hypoxic ischemic brain injury with hypothalamic dysfunction. So let's consider a few different patients. Patient 1 presents with spontaneous hypothermia, presents at the hospital with a temperature of 34 degrees Celsius. They're connected to a temperature control device at hour 4 once they're in the ICU, but they actually achieve a target temperature of 33 prior to device connection just by exposing them to room temperature air. Patient 2 presents with fever, is immediately connected to intravascular cooling within 2 hours of return of spontaneous circulation. It's treated with full dose paralysis with 1.2 mg per kg of rocuronium and rapidly achieves target temperature by hour 4. Patient 3 presents with a core temperature of 36, is quickly connected to a surface cooling device within 2 hours. But no one on the team recognizes that this patient is having uncontrolled shivering and generating heat, which you can see in this red circle here. 4 bars up on the trend indicator indicate that this patient is going to warm by a degree within the next hour. And this is partly due to low flow rates and likely also due to uncontrolled shivering. This patient doesn't achieve target temperature until hour 8. As you can see by these examples, the time to achieve target temperature is not the metric that we want to use because it's confounded by illness severity. Patient 1 and 2 have the same time to target temperature. However, their chances of neurologic recovery are extremely disparate. Variable methods for temperature control induction are another reason for the translational gap. While we'll spend more time discussing which parameters may be part of high-quality temperature control, it's also plausible that failure to address shivering thermogenesis may result in increased energy expenditure that not only counteracts the neuroprotective mechanism of temperature control, but may in fact actually be harmful. High-quality temperature control is a framework that focuses on delivery of a standardized intervention with optimized parameters. When we talk about high-quality temperature control, we must address several factors, such as the methods for hypothermia, the pre-induction and induction times, the depth and length of hypothermia, adjunctive treatments for shivering thermogenesis, and the rate of rewarming. Tacone and colleagues have identified and defined one type of high-quality temperature control using the 6 variables seen in Table 2. This includes time from arrest to target temperature, overcooling, overshoot, temperature variability, the rewarming rate, and the incidence of fever. And using a score of 7 to 9 to define high quality, they found that actually only 16% of patients enrolled in the time-differentiated therapeutic hypothermia or TTH-48 trial were treated with high-quality temperature control. While these factors all likely impact the quality of cooling, they've really focused more on patient-specific factors rather than treatment-related variables. For example, a short time from arrest to target temperature may not in fact be due to high-quality temperature control, but rather someone who presents cold and is unable to shiver or generate heat. So our group at Yale recently published this study in the Annals of Emergency Medicine. Rather than looking at time to target temperature, which is flawed for the reasons we discussed, we focused on the pre-induction time, defined as the time from hospital arrival until the initiation of temperature control with a closed-loop temperature feedback device. This study was a retrospective, single academic center study which evaluated 347 consecutive out-of-hospital cardiac arrest patients treated with temperature control between 2014 and 2022. We defined early pre-induction as less than 3 hours based on prior literature. For the overall cohort, the median time from hospital arrival to device initiation was 4.5 hours. And 22% of the cohort met the definition for early pre-induction. Amongst that cohort of 75 patients, the median time from hospital arrival to device initiation was 2.5 hours. As seen in Table 1, the overall cohort differed from the TTM2 cohort, with 33% shockable rhythm, 44% bystander CPR, a mean lactate of 9, and a median Pittsburgh cardiac arrest category score of 4. In the far right column, you can see the standardized mean differences between the early and the late pre-induction groups. Patients who received early pre-induction were younger, more likely to be male, had lower comorbidities, and a higher incidence of shockable rhythm arrest. We performed sensitivity analysis using inverse probability treatment weighting to minimize measurable confounders. And as you can see in Table 2, in our sensitivity analysis, all key baseline characteristics and covariance were well balanced. In this figure, we show the outcomes for patients before and after inverse probability treatment weighting. 28% of patients treated with early temperature control achieved good neurologic outcome, which was defined as a cerebral performance category score of 1 to 2, while only 15.5 in the late cohort achieved this metric, and that results in an odds ratio of 1.95. We also found that early pre-induction was associated with improved survival to hospital discharge with an odds ratio of 2.14. As you can see in this figure, we identified a linear association between pre-induction time and the log odds of good neurologic outcome. In fact, each hour delay in the time to initiate a temperature-controlled device was associated with a 20% decrease in odds of good neurologic outcome and a 16% decrease in odds of survival to hospital discharge. As seen earlier with patient number 3, rapid initiation of hypothermia using a temperature-controlled device may not be enough if a patient has the ability to generate heat, thereby preventing a drop in their core temperature. As previously discussed, in patients with preserved thermal regulation, shivering is a natural process that occurs when a patient is exposed to hypothermia. Neuromuscular blockade can be used as a treatment during temperature control induction to inhibit shivering and increase the induction speed. In this post-hoc analysis of a prospective multi-center observational cohort, 516 patients treated with temperature control were included. Patients who received neuromuscular blockade during temperature control were more likely to achieve good neurologic outcome and hospital discharge than patients who were not treated with neuromuscular blockade. Furthermore, the time to achieve target temperature occurred in 3.9 hours in patients who were treated with neuromuscular blockade versus 6 hours in patients who were not treated with neuromuscular blockade. That's a gain of 1.5 hours. In our cohort, we looked also at the use of neuromuscular blockade within the first 6 hours of temperature control initiation and found a similar effect, that the use of neuromuscular blockade was associated with improved neurologic outcomes. Based on this data, we set out to define high-quality temperature control based on provider treatments, such as the time it takes a provider team to initiate a temperature control device, and the use of sedation and paralysis to augment shivering thermogenesis. As you can see in this table, our quality score ranges from 0 to 6 points, with a score of 0 reflecting the lowest quality temperature control, and a score of 6 reflecting the highest quality temperature control. Seen in the figure below, you can see that as the quality score rises, so does the log odds of good neurologic outcome. Our cohort included 391 out-of-hospital cardiac arrest patients treated with temperature control, and we used similar methods to what was used in our prior trial looking at pre-induction times. Specifically, we use inverse probability treatment weighting to minimize measurable confounding. We binarized the cohort into low and high quality, where high quality was defined as a score of 3 or above on the quality score, and this was based on the Uden index. As seen in this figure, high quality temperature control was associated with an improvement in both good neurologic outcome and survival to hospital discharge, with an odds ratio of 1.98 and 2.06. And as you can see in the orange or red colors, the high quality cohort had a higher rate of good neurologic outcome, 11.8 compared to 17%, and a higher rate of survival to hospital discharge, 19% compared to 40.5%. Unfortunately, there are implementation barriers that influence the ability of providers to achieve early, high quality temperature control. In survey studies throughout Europe, only 15 to 20% of sites report initiation of temperature control in the emergency department, with most sites waiting until the patient arrives in the ICU to initiate cooling. In a recently published survey study of ice cap trial sites in the US, emergency department boarding exceeded 2 hours at 42% of sites, and there were many identified barriers for the early initiation of temperature control. Using multi-select responses, the site principal investigators indicated that clinical nihilism regarding the importance of early temperature control was actually the #1 barrier. Hopefully, this talk will help to combat that challenge. However, the barriers really go beyond an educational gap. Over a third of respondents indicated that lack of access to a cooling device and nursing availability impact the ability to initiate temperature control in the emergency department. I'm sure most of you have experienced that emergency department boarding times continue to rise, and patients resuscitated from cardiac arrest may spend the golden hours in the emergency department. This time is critical as it's when early interventions likely have the most influence on mitigating secondary brain injury. In order to move forward, we must understand the therapeutic window of temperature control and the optimal methods required to achieve high quality. This can and should be addressed prospectively. Large pragmatic trial designs will not address this knowledge gap, and smaller, highly controlled trials at sites that have the local infrastructure to deploy rapid cooling will be essential. We are currently working with the SIREN Network, which is the Strategies to Innovate Emergency Care Clinical Trials Network, to design a prospective trial to understand the relationship between specific temperature control parameters, such as the reinduction time, and clinical outcomes. We believe that it would be unethical to randomize patients to low versus high quality temperature control. And we instead plan to use a stepped wedge design to observe natural between site variability and within site variability in temperature control practices, and a delayed implementation of an emergency department high quality temperature control protocol. We believe that work must be done on the implementation side to improve individual sites' use of high quality temperature control. Although our definition of high quality is an exciting first step, only 40% of our cohort met the definition for high quality, and actually very few patients achieved a score of 4 to 6. In order to truly assess the impact of temperature control parameters on treatment efficacy, we must develop a framework for achieving early high quality cooling. But we also need to identify the population who's most likely to benefit in order to enrich our trials. Going back to this figure that I showed earlier, we need to design trials that enhance enrollment of those in this middle group, the population whose outcome may be positively altered by treatment with hypothermic temperature control. While some of the tools that have been defined, including the RCAS score and the PCAC score, these tools also require some neurologic evaluation. The RCAS score requires a GCS motor score, and the PCAC score requires an evaluation of brainstem functions, which may not be feasible at every center. Additionally, most of the work on these scores has been to predict poor outcome, and there needs to be more work done regarding the influence of illness severity on the likelihood of benefit with moderate hypothermia. In order to minimize selection bias, we need to prospectively evaluate studies that include phenotyping, not just by presenting rhythm, but by post-cardiac arrest illness severity. Prior to identifying the just right group, we also need to identify those who are the least likely to benefit from hypothermia. Scores like the brain death risk score may help to standardize objective exclusion criterion. This score ranges from 0 to 7 and includes 5 variables to predict brain death, a definitively poor outcome, which is unmarred by withdrawal of life-sustaining therapy. A brain death risk score of 5 or above showed a high area under the receiver operating curve of 0.849 to 0.931 in a development and validation cohort at 2 Northeast academic medical centers. This score, however, needs further validation, as some of the components, such as the HEG commutative tomography and the FORCE score, may include subjective interpretations or may not be feasible at individual sites based on site-related practices. In summary, the current guidelines recommend active fever avoidance, which often requires the use of a temperature control device. While there is insufficient data to recommend for or against active temperature control at 32 to 36 degrees Celsius, there is some suggestion of benefit amongst those with moderate severity post-cardiac arrest syndrome. Given conflicting data, I think using an individualized approach supported by illness severity scores is appropriate. I would also recommend drafting protocols based on the available data, but not generalizing the TTM2 trial data to your entire cohort unless the population that you treat closely mirrors the population enrolled in that trial. As a community, our research priorities must include early phenotyping to improve patient selection, defining and standardizing high-quality temperature control, and addressing implementation challenges and barriers to providing early, high-quality temperature control. I'm going to take any questions now. Hopefully, I left a good amount of time for interactive session. I just want to quickly acknowledge the amazing cardiac arrest.
Fantastic. Fantastic presentation, Dr. Rachel Beekman. We'll now transition to our Q&A session. So if you're in the audience, please put your question in the Q&A box. All right, our first audience question here says, is there any known benefit to intravascular temperature control versus temperature control with body surface cooling pads?
It's a really good question. And I think some of that really depends on the structure at your site and what resources are available. So there are some studies that look head to head at surface cooling versus intravascular cooling. And overall, the majority of these studies don't show that one is superior in terms of good neurologic outcome. But intravascular cooling has been shown to have decreased nursing requirements. It has been shown to have decreasing variability in temperature, decreased overcooling, which could minimize the potential arrhythmic effects of cooling. And depending on your site practices, one may be superior. So intravascular cooling is largely provider driven, right? So it provides central access, which at our center, most patients do require central access for the use of vasopressors. So it's a 2-in-1 therapy. But it also is placed by the provider team. And so if you have a provider team who's active in the emergency department and willing to place those catheters during their resuscitation, it may be started very quickly and can be extremely effective at lowering the body temperature quickly. Surface cooling is predominantly nursing driven and does require nurses to place pads, which require turning a patient who just achieved return of spontaneous circulation, which of course could lead to some hesitation depending on the etiology of arrest in that patient, may lead to delays. It does require skin checks and a little bit more monitoring from the nurses, which could be a challenge with initiating in the emergency department based on what resources your team has available.
The next one says, can you tell me what drove the decision for Yale to use PCAC instead of the RCAST scoring tool for your study?
Thank you. It's a great question. So we record both of those, and I think they both have, they're very similar actually in terms of prediction. For our cohort, we were able to derive a Pittsburgh cardiac arrest category score more easily on all of our patients based on the data that we have in our database. And the RCAS score was not available. We had some missing features, including lactate level on some of our patients. And so we chose the scoring system that would be readily applied to all of the patients in our cohort. But they do align for most patients, and overall are both highly reliable in predicting outcomes.
Great. This one dives into hypoxic ischemia. So, given that the severity of hypoxic ischemic brain injury varies according to the extent of hypoxic ischemia, quality of CPR, and post cardiac arrest syndrome, how can temperature therapeutic hyperthermia protocols be optimized given that list?
Yeah, I mean, I think this is a great question that gets at who is the population who benefits most from increased depth of hypothermia. So, you know, many hospital protocols do not actually adjust based on individual features. There are some hospitals that are successfully using illness severity scores to decide what temperature to cool patients at. But this requires a team-based approach where the patients are being seen by a standard post-arrest team where the philosophy is somewhat similar. It becomes a little bit harder to protocolize that, although there are definitely ways that you can write a post-arrest protocol using set illness severity scores and use an algorithm based to predict what temperature you're going to set the patient at. Well, I find the illness severity scores extremely valuable, and I often am using that to determine what patient's temperature should be. Our algorithm at Yale is actually quite different. So we actually use the presenting temperature. And the reason that we do that is because presenting temperature is likely also predictive of illness severity. So that's work that I showed previously in terms of that patients present spontaneously hypothermic overall have a higher mortality rate and likely benefit more from moderate hypothermia. But the guidelines also, while they don't specify what the optimal temperature is for each individual patient, they do specifically say that patients should not be rewarmed. And so by using core temperature to help us guide temperature, target temperature, we are making sure that we are not actively rewarming patients who present spontaneously hypothermic.
If a patient is having rebound hypothermia after the 24-hour cooling period, what is the recommended time to continue treatment to prevent any level of temp above normal thermia?
Thank you. That's a great question. So often in the maintenance phase, patients will have either very low water temperatures, which is a sign to you that they would likely be febrile if the device was taken off, or they might actually have very high water temperatures that suggests to you that that patient would be hypothermic if you took that device off. Our practice is that we maintain the device for 24 hours from the time that the patient is either showing signs that they would be hypothermic or hyperthermic when the device is taken off. So we use a water temperature of less than 10 to indicate that that patient would likely be febrile. And if the patient is having water temperatures below 10, we actually will extend the use of the normothermic phase because we know that if we take the device off, they would become febrile.
Great. So this next question asks about different patient populations. What is the optimal time for target temperature management across different population sizes, adults, pediatrics, and infants?
So I can't comment much on infants and pediatric as I am an adult neurointensivist, but I think one thing to take into account is that the data for temperature control in pediatrics and adults has been quite variable, while the data in neonates has actually been quite strong. And that's why temperature control has been a guideline recommended for hypoxic ischemic encephalopathy. If you think about that a little bit more in the context of what we spoke about today, neonates actually don't shiver. You expose them to ambient temperature and they rapidly drop their temperature, while pediatric patients and adult patients will shiver. It is a natural response if you have intact thermogenesis to any sort of cooling. And so I think that that is suggestive to me as well that that our pediatric and adult data is limited by the methods that we use to drop temperature, and that the treatment of shivering thermogenesis is essential. The data that we have in adults, I've shown you most of the data that we have, and I do think it suggests, and that more data will hopefully come out, that the time to initiating the intervention and the methods that we use to mitigate shivering thermogenesis are essential to an effective therapy, but we don't know the therapeutic window. And I think we do need to design multi-center prospective studies that look at variability between sites to understand what is the therapeutic window, and if connecting a device at 6 to 8 hours actually provides any neuroprotective benefit. And by defining some of these parameters, hopefully we can move forward to discussing what the optimal metrics are, and then reevaluating some of the questions that we've already evaluated with a different framework looking at high quality temperature control.
Great. We have time for one or two more questions. This one says, do you think that it would help to start the cooling already in the ambulance?
So there have been many pre-hospital trials which have not consistently shown benefit. I think part of the reason that pre-hospital trials have not shown benefit is the methods. So we know that in patients with shockable rhythm arrest who have high likelihood of cardiac dysfunction, that giving cold saline is not only not helpful, it might be harmful and increase the risk of rearrest. Transnasal cooling studies pre-hospital have overall been mixed, but when you pool the analysis together, suggests that there may be benefit specifically in the shockable rhythm arrest group. I know that there is a trial that is proposed in Europe, which is going to be looking at pre-hospital cooling and then continuing cooling in the hospital, because one of the concerns about the transnasal cooling studies was that they did effectively drop the temperature, but then when they got to the hospital, they did not maintain that low temperature, and that likely affected the overall results. And so I think more to come on pre-hospital cooling and the effect, but I think likely the earliest cooling, the better, but there are patient-specific factors that need to be taken into account, and so it is unfortunately not going to be a one-size-fits-all.
Fantastic. So we were flooded with audience questions, but we are out of time. Thank you, Dr. Rachel Beekman, for that phenomenal presentation. Thank you to the audience for tuning in and asking your questions. And thank you to Zoll for supporting this webinar. So this webinar will be made available on demand within the next 48 hours. So make sure to come back and check out the presentation for anything that you missed. Until then, we hope you'll tune in for another webinar from Marianne Liebert. We'll see you next time.